So my buddy Tim bought a jet ski.
Mm-hmm. Oh, dude, I was just talking about buying jet skis the other day. Because both of my buddies have boats, and I'm like, I'm not buying a boat. I'm going to buy 2, 3, 4 jet skis and just, yeah.
I'll be honest with you, we have kind of always said that if we ever made it big, we'd buy jet skis.
Yeah.
And we have almost made it big.
So we're almost going to buy jet skis.
To buy jet skis. So,
yeah.
Anyway, really excited about it. Every year, my sister-in-law, so Natalie's sister's husband's father.
Okay.
So my brother-in-law's father.
On the other, yep, okay.
Goes out for Father's Day on his boat, and we go out on the lake.
Dude, take the jet ski.
So no, here's what I'm thinking. It's like a Father's Day thing, right? But it's like neither of the people I'm out there with are really like my dad. It's my father-in-law and it's my sister-in-law's father-in-law.
Okay.
So I'm thinking Tim kind of comes and rescues me from it, right? He drives out the 2.5 miles, and then I'm like, sorry, everybody. I like throw my backpack like as a spy wheel. I'm like, sorry, everybody. It's time to hang out for Father's Day with my daddy. Jump on the back, wrap my arms around him, and then he drives me away.
And you're just done then?
So I imagine that scene.
You're just done then?
Awesome.
Are you coming back? Are you coming
I'm
back?
honestly considering like actually doing this like as a joke.
Are you going to tell your own wife?
Maybe coming back. No.
Is she going to be on that boat?
I think, yeah.
You're just going to abandon ship.
So funny. How funny would it be if like, because
how
like,
far are you going to go though? Because here's the thing. It's like, I'm just
like
picturing this open lake. You have to get out of like sight to land the joke. You just have to go on that jet ski for like a while. Until you can like dip behind an island to disappear in the sunset.
His jet ski goes like 65 miles an hour.
That's awesome.
Maxed out. I don't think we're going to max it out, but like, I think it'd be a really funny joke.
Cool. He's got to find you on the lake. You got to like.
Yeah, but we go to like a point that's like
a
well-known point.
That'd be, yeah, I mean.
I think it's be hilarious. All right.
Good
anyway,
luck.
Welcome to the Back to Basics podcast. This is a podcast where me and my brother, we're both medical providers. I'm a nurse paramedic. He is a ER physician. We take complicated medical topics and we break them down to basics.
Or at least we try to.
Yes. Sometimes we go on tangents about
jet skis
or dogs last time, orca whales.
You know what?
A lot of strange things. So we're going to try to keep it nice and tight in this one and just get through it. We're going to try to keep it to a half hour. But this is a two-parter. So what we're going to do is we're going to cover ACLS. We'll talk about what that is and how it all works. But we're going to cover ACLS, the general topics of ACLS, in a part 1 lecture and a part 2 lecture. So you should listen to these back-to-back, and then you'll get 2 half credits for it. We're going to try to keep them to half hours. But that's a challenge because there's a lot to cover, and a typical ACLS course is multiple days. However, let's talk about what ACLS is. ACLS is Advanced Cardiac Life Support. It is the most popular ACLS is given by the American Heart Association. Mm-hmm. It's like a licensure that you can get. And it's kind of a staple in the, medical community, I would say, in terms of like getting some advanced training. And it basically, when it comes down to it, covers 6 emergencies. And these are emergencies that you can experience in the field as like an EMS provider, or emergencies that you can experience anywhere in the hospital too, right? So you'll usually have like critical care teams or rapid response teams that will respond to things like codes on your floor. They would all need to be ACLS certified typically. So if you want to be involved in that, you may need to be ACLS certified as well. So ACLS, Advanced Cardiac Life Support, covers 6 cardiac emergencies, technically 5 cardiac emergencies and 1 neurological emergency.
Sure.
So it covers your heart has stopped, so you're dead, cardiac arrest. Your heart has restarted after dying, rosk, return of spontaneous circulation. Your heart is going too fast, tachycardia. Your heart is going too slow, bradycardia. Your heart is having a heart attack, acute coronary syndromes. And your brain is having an attack, similar to a heart attack, you're having a stroke. That is the gist of what ACLS is. Mm-hmm. And it basically applies algorithms, which are just fancy way of saying a nice systematic step process to how to treat and handle these emergencies and identify them. Chris and I are both ACLS instructors. We have been for years. I personally have taught ACLS just under 1,000 times.
Really?
Yeah.
I did the math
one time.
Wow.
It was crazy.
That's nuts.
So a lot of ACLS.
Yeah.
We are not, some of the things that we're not going to do, we're not going to do like, we'll give you kind of general guidelines on how the treatment works. We're not going to give you any dosages or anything that's like AHA specific or Red Cross specific or anything like that. Those can change, so do your own research. This isn't going to count as your licensure for ACLS, so definitely attend the classes, but hopefully this will give you a good idea of kind of what you'd be getting into and learning in the process. Mm-hmm. Fair enough? Because I know what's going to happen is people are going to be like, that's the 2018 guidelines, blah, 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 blah. We're going to talk about general treatments. These treatments don't really change.
Right.
Okay? Today we're doing in part one.
Part one, we're going to do cardiac arrest and return of spontaneous circulation.
Yes.
These are the most fun ones. I don't know. I like cardiac arrest and rosk, and here's why. I like that we have created rosk as its own emergency. Like, I think for so long, and a lot of times people still do this, they look at cardiac arrest as both the cardiac arrest component and when we get somebody back. And what I like about separating those two is that, like, what we do, I like splitting them up because there's such important aspects of how we treat cardiac arrest. And there are some very specific ways in how we treat return of spontaneous circulation that they need to be separated, because we lose emphasis on what we do after we've gotten pulses back a lot of times. And that can be such a critical component to someone's morbidity, mortality in the long run, all that kind of stuff. The goal is not necessarily to get someone's heart beating and then you're done. Like, the goal is to get someone's heart beating and have them go from there to be able to, like, have quality of life again.
Right.
And there's a lot of key components that have to play in acutely when that happens, and you got to do it right if you really want to get to those endpoints.
Yeah, Kendra, our sister, just sent me an article last night, actually, that was like, hey, is this too negative? And it was basically an article about, like, outcomes of CPR and how negative they can be sometimes. And I was like, no, not really, but here are some, like, factors, you know. But, like, people don't realize that, like, you don't do it right. You know what I mean? If you're not doing rosk right, quality of life is going to drop quite a bit there, right? This also isn't BLS, all right? So we've done a lot of courses and credits and things like that on BLS, on how that works, on how CPR works, on how an AED works. We're going to kind of very quickly cover that so that we can jump into the advanced component of that and now how, you know, static and dynamic EKG rhythms work and sort of some of that stuff.
But I would say that does, like, what we cover today is less important than those things when it comes to cardiac arrest and rosk. Right? High quality CPR, good quality chest compressions, all that stuff is way more important than the stuff we're going to cover today.
Right.
So I think a lot of times it's easy. We see advanced cardiac life support instead of basic and think it's more important. Definitely not more important.
Right. So, yeah, ACLS is built off of good BLS, and it's useless without it. Mm-hmm. So, just want to be clear on that. You can check out our other lectures. You can check out our other podcasts that cover more BLS topics. We would encourage you to do that, but we're doing ACLS today. All right. So, real quick, what is cardiac arrest? Cardiac arrest is when your heart stops and you're dead. All right. When your heart stops, you are defined legally and clinically as dead. Right? You may be revivable, but you are dead. People, I think, tend to think that cardiac arrest is like a special way to die. No, you always die from cardiac arrest, right?
The end point to life is your heart stopping.
Is your heart stopping in cardiac arrest. So when people say, like, he died from cardiac arrest, as opposed to, like, that guy died from trauma. It's like, no, that guy died from cardiac arrest too.
Due to trauma.
Yeah, due to trauma, right? So cardiac arrest is just the stopping of the heart.
It's worth making that point because I think we do this when we teach our basic classes and stuff, but, like, the person can't get worse. So everything you do from here is critically important, and you don't need to shy away or be fearful, I think, of sometimes of some of the aspects of cardiac arrest care, because, again, you can't really make the situation work. Yeah, you can not make it better. Like, you could do this not well, and there, you know, but, like, even the save rates for people who've gone into cardiac arrest when we do utilize basic life support and advanced cardiac life support techniques is very low.
So it takes the pressure off. Yeah. You're not getting any deader. Do the best you can.
Yep.
Don't do anything that would be extra harmful. You know what I mean? Don't, like, also cut off their limb, but, you know, everything that we're going to be doing is going to be in an attempt to help, and you're protected in that too. We talk in our BLS stuff about Good Samaritan laws and stuff like that. Again, this is different. We're not talking about CPR today. We're talking about CPR as a component of advanced cardiac life support. So this is medical provider treatment. We're giving drugs. We're doing things like intubation. We're doing advanced airways. We're doing capnography. There's a lot of components to this. So let's start with recognizing cardiac arrest and then what we do, and then we'll kind of just really quickly cover, and I have this a little bit out of order on our notes, Chris, so I apologize, but we'll cover, like, AED usage and what it does, and then we'll shift back to, like, okay, EKG interpretation. That work for you? Cool. That's how I would typically do it. So how do we recognize that someone is dead?
They don't have a pulse.
They don't have a pulse, right? And this would be a palpable pulse. So we're going to try to feel their pulse in their neck. We always go for the neck because it's closest to the heart, and that's where we're most likely to feel the pulse. If they don't have a pulse, the only treatment that we're going to do is begin CPR.
I will say, I'll put a couple caveats here already. One, if you have someone hooked up to an EKG and you see some type of rhythm, that's not...
Doesn't mean that they have a pulse.
Doesn't mean they have a pulse. If you hook somebody up to a pulse oximeter even, and they have oxygen readings, but you don't feel a pulse, they don't have a pulse. The only thing, though, that is a better indication... Okay, I'll throw another one in there. Ultrasound. You put an ultrasound on someone's heart. You see cardiac activity. You see the heart beating, pumping. If they don't have a pulse, they don't have a pulse. The only thing outside of feeling for a pulse and not feeling it that can define cardiac arrest is capnography. Yes. And we did a whole podcast and credit on capnography. Take a look at that. Other than that, if you don't have capnography, you put your finger on their carotid. If you don't feel it, they need CPR. They need cardiac arrest care. Like, I think we have so many of these other techniques to look at other different aspects. Don't lose sight of the fact that when we look at the data and the research today, the best way to figure out if someone's in cardiac arrest is capnography. And if you don't have capnography, do you feel a pulse? And if you don't feel a pulse, you start CPR.
Right. So we've confirmed that they don't have a pulse. We're going to go ahead and start compressions. What compressions do, and we talked about this before, is we are basically shoving the rib cage down onto the heart muscle in order to squeeze it, in order to build up pressure in the heart. I used an analogy that was kind of crazy in our BLS thing, and I think I compared it to a sponge. Or I said it's not like a sponge, and then that TikTok got over 1 million views of people just basically saying this is a terrible analogy. And you know what?
But we got the million views.
Yeah, so I'm going to try to use more bad analogies in order to try to increase our virality.
I like it.
So what basically you're doing is you're building up a pressure in the heart so that the blood can start to move through your vessels because they're all connected. It's a pump. You're building up a pressure, and then you're moving and circulating that blood. Then hopefully the heart itself can perfuse. It can get enough oxygen to start beating on its own again, okay? That is the mechanical part of the beating heart. The electrical part of the beating heart is that you can have certain rhythms that will not cause the heart to beat. For instance, if I have a rhythm that is beating at 300 times per minute, the heart can't actually beat that fast, right? It can't fill up in that. So if my rhythm is, the electricity going through the heart is 300 times a minute, the heart won't be beating. I won't have a pulse, but there's still electrical activity in there. So just because you're dead and your heart's not beating doesn't mean that there's not an electrical rhythm moving through that heart. So that's where the EKG interpretation kind of comes into it, and that's where the use of an AED can come into it. So there are two shockable rhythms. One is called ventricular fibrillation, and one is called ventricular tachycardia, pulseless, that we will shock with an AED. And what the AED does is it resets electrical activity and stops your heart so that with good CPR, we can restart it and get another cleaner rhythm, all right? That's the simplest way I can put it. Now we're going to jump into a little bit more about like how EKGs work. Is that fair? Any questions or any things you would add to that?
Sounds great.
Okay. So normal structure and function of the heart. You have your atria, are your upper chambers of your heart, and your ventricles are your lower chambers of your heart. And Jamie, I think what we're going to need to do is put up a picture of a heart at some point on this. I'll walk you through it. All right? So we're going to have a picture of a heart pop up. You have an SA node that's located in the upper left portion of your heart. It's in the upper chambers. Was your left in the picture?
Yeah, you were left in the picture, but you were right in your body.
But you're right in your body.
The right atria.
Yep. In the right atria, you have this little node there, and it's this cluster of electrical cells that is the pacemaker for your heart. So that is the structure that is responsible for starting the electricity to travel down this pathway that you'll see a picture of now. And it's going to travel down this pathway. It's going to go through the junction of the heart where the ventricles and the atria meet, and then it's going to split off into two paths called the bundle branches.
Oh, sorry.
And
okay,
then
gotcha.
the bundle branches that are connected to the Purkinje fibers that will stimulate the lower portion of the heart down here. So the process is basically it moves down and it almost moves like a fish hook does. And it goes down and then it splits off into those things. Then it comes back up to stimulate the ventricles. Now, I want you to imagine that there are a set of eyes at the lower right portion of this picture. So looking at the lower left portion of an actual heart. The eyes are here. They're going to pop up. Now that I have this technology, I'm going to use it all the time.
Someone listening to this podcast, though,
that's fine.
Is going to be...
But if they're getting a credit, they're watching it. So
okay,
this is how we got to work it out. All right, so So you're basically looking at the heart from the lower right corner of this picture of the heart. We're looking up at the electricity. What an EKG does is we put a lead down there and it reads electricity heading towards that set of eyes or towards the sticker that we put on their skin. So normally an EKG, when you have the SA node fire and electricity goes through the atria and gets to about where the bundle branches are, whenever electricity moves towards that lead, we have an upward deflection on the EKG. And that's going to be the form of a P wave. Okay, we call this first little bump on an EKG a P wave. Positive deflection because it's headed towards that set of eyes.
And that's the electrical activity moving from the top, from the SA node through the atria towards those eyes that are looking up at it.
Yes. So when we say that someone has a positive P wave, we can assume that their atria are depolarizing. This does not mean that someone has a pulse, because remember, you can have an electrical rhythm moving through your heart but still be dead. Okay, there are dead bodies out there right now. That's kind of a weird, sure, right now, right? Like in an emergency, if Chris went down right now, there is a chance that he has the same heart rhythm that I have in my heart, but he's dead on the ground and doesn't have a pulse because that rhythm isn't generating enough electricity to get the heart to pump at that rate and rhythm. Mm-hmm. Got it? Okay, so that's the P wave. That's the first little portion. Represents the atria. Then, as you know, it splits into these two bundle branches, and it's moving now towards those set of eyes. So we still have a little bit of a positive deflection, and that's a first half of what we call the QRS wave. All right, and that's going to look like this. Then, as you can see, we curl up the sides of the ventricles, and now it's moving away from that set of eyes or away from that camera view or sticker. So now he's going to read the electricity is moving away from him, so he's going to scribble down, and that gives us the second half of the QRS wave. So we have a P wave and we have a QRS wave. The P wave represents the atria depolarizing. The QRS wave represents the ventricles depolarizing. Now, what we really care about in medicine is the ventricles depolarizing because that has the most amount of blood in it. So whenever the ventricles depolarize, that's when the heart well and truly beats, right?
Which is why someone who has atrial fibrillation, where the top of their heart's just kind of shaking, not pumping, is pumping blood fine and can have a pulse and just sit in that rhythm. Because the ventricles, like blood is getting to the ventricles are then pushing that out to the body.
Right. Now on an EKG, we have a third little bump on there called the T wave. It's a larger bump. And that is the repolarization or resetting of the ventricles. And because the ventricles largely are repolarizing from top to bottom, it's a big positive deflection. And the reason that we don't see the repolarization of the atria is because that would be happening during the QRS wave that we saw previously. So this little guy in the corner that's viewing the heart, this EKG, is only reading electrical activity. It doesn't matter if it's repolarization or depolarization. He doesn't care if it's positive or resetting, negative energy. He's just going to read it and scribble on there. That's the gist of what a normal EKG should look like. You have a P wave, a QRS wave, and a T wave, which is the repolarization. And then depending on how we look at those scribbles, the rate of those scribbles, the rhythm of those scribbles, the changes in morphology is how we determine a lot of cardiac conditions. Now, some of these are going to be more important when we talk about tachycardia and bradycardia because it's going to be the rate of the QRSs, but we'll get to that. So what happens if that SA node, that pacemaker, fails? What's exciting about the heart is that any cell, any cardiac cell, electrical cell in the heart can actually take over as the pacemaker. So if my SA node fails, typically my AV node will take over. If my AV node fails, I can have any cell in the heart, it could be in the atria, it could be in the junction in that middle area, or it could be in the ventricles, take over as the active pacemaker. But that's going to change the direction that the electricity is moving because it has a new origin point. So how that little guy or that EKG views the heart's electricity is going to be different. And essentially there are three neighborhoods that a cell can be coming from to generate that electrical activity. It could be in the atria, in which case we see a nice positive P wave like normal, and we have a nice positive and negative QRS in the T wave. It could be in the junction, which could actually reverse the polarity of the P wave. So the P wave might be opposite. I shouldn't say polarity. That's not a very good description.
So
but
basically,
the direction of the P
wave. If the cell that's triggering the pacemaker now is down in the junction, then when it depolarizes the atria, that electricity has to go up instead of down. So it's coming from the SA node, it's going down. If it's coming from the junction, it's going up. So if it's going up, then the eyes see it going away from it. So it's going to cause an inverted P wave.
Right. Or it might not have any P wave at all if the
somewhere in the middle
that's stimulating the ventricles is beating out the electricity that's stimulating the atria. Sure. So you could have a negative P wave, or no P wave at all in a junctional rhythm. And then there could be ventricular rhythms where we have an automatistic beat that's starting in the ventricles. If that's the case, we're going to be on one side of the heart or the other. So no longer are we above those bundle branches where we can split off into two bifurcating ways, right? So it's going to take a longer period of time to jump onto this highway and then head backwards back to the junction and then go all the way to the other side of the heart. And that time on an EKG graph is represented from left to right. So ventricular rhythms always have very large QRS complex, big wide QRS complexes that look like this. So that's the gist of what EKG should look like. Half of reading EKGs are just trying to figure out how fast something's going and what neighborhood the electricity originates in. And we'll talk about why it matters in just a second. But first, how do we read an EKG? Step one, we look at the rate of the EKG. How do we do that?
You're counting the squares.
Count the squares, right? So
right from left to right is time. So how many beats are happening in a period of time?
Right, and we already talked that beats typically are the QRS complexes because that's when the ventricles are beating. Again, this is in a patient with a pulse. So we would count all of the QRSs in a 6-second strip, and we could multiply that by 10, and that would tell us our heart rate. What's another way to get heart rate? Feel their pulse rate and count, right? But read that on the EKG, that's how we would do that. There are some other ways to do it, but the street cheat, easy way to do it is look at a 6-second strip, count the QRSs, multiply that by 10. Then we're going to look at the overall rhythm. Is it regular or is it irregular? The best way to look at this is look at your R waves, the top of the QRS to the top of the next QRS, and then look at the next one. And if those spaces are even throughout, then we know that it's a nice regular rhythm, right? Then we look at P waves because we want to try to figure out what neighborhood this pacemaker is existing in, right? If we have a positive P wave, then we know that it's in the atria or it's the SA node itself. If we have a negative P wave, then we know it's in the junction. If we don't have a P wave, it could either be in the junction or the ventricles. Then we look at the QRS waves. Now we want to know if it has a narrow QRS, then I know that that's a junctional rhythm with no P wave, right? Or if it has a wide QRS, I know it's a ventricular rhythm. And then lastly, we look at the ST segment because we'll talk about this more when we talk about ACS, but we look for ST elevation or depression, which can be a sign of a heart attack. And that's how we read an EKG, those 5 steps.
Love it.
Fair enough. I know that's a lot of textbook information. Hopefully we'll get some images up there to kind of help walk you through that. But that's sort of how we read an EKG. In cardiac arrest, what happens is the heart has stopped, but there could still be electrical rhythm within the heart, right? So our options essentially are there is no electrical rhythm, which means we have a flat line in the EKG, or there is electrical rhythm and it's normal, which would be any type of electrical rhythm you can think of besides VFib and VTAC. So for instance, normal sinus rhythm, the same heart rate that I have right now, heart rhythm and rate, it's exactly the same, but the heart is dead. There are certain caveats that we need to make sure that we wouldn't want to shock that rhythm because shocking is resetting. I'm happy with what that rhythm is. I'm not happy that the heart isn't beating at that rhythm and rate. So in this case, that patient would just get the CPR and some other things, but we wouldn't shock that rhythm at all.
And we call that pulseless electrical activity. So it's electrical activity that's like an organized, regular activity, but there's no pulse. So pulseless electrical activity, or PEA.
Right. In a flat line or asystole, we wouldn't shock that either. And because if we shocked a flat line, we would put someone into a flat line. It wouldn't do anything. We'd stop the heart. We're stopping nothing. And there's no point in doing that. So we don't shock a flat line either. So we don't shock PEA and we don't shock asystole or a flat line. What we do shock is called VFib. We're going to have it printed up on the screen right now. It is basically a very fast and irregular ventricular rate. It looks like a bunch of nonsense on the EKG. If we see something like this, that's a shockable rhythm. This is a rhythm that is the cause of the cardiac arrest could be because that we're in this weird rhythm, and we're not going to get a pulse back until we fix that. All the CPR in the world isn't going to help this because what we need to do is reset the electricity in the heart first. So we shock that, we reset it, and then with good CPR, hopefully we turn on the SA nodes, we get a nice normal sinus rhythm, or maybe we turn on a different backup pacemaker that's a little bit more organized where we can actually beat our heart and survive.
And same with pulseless ventricular tachycardia.
Yeah, and
so it can be kind of more organized looking because it's constant, big, wide QRS complexes. So we know it's a ventricular tachycardia. It's going too fast, and it's coming from the ventricle because it's wide, but there's no pulse. So pulseless VTach is another shockable rhythm.
And with pulseless VTach, you can sort of think of it this way. If I were to resuscitate the heart and get it beating at this rate, this is such a fast rate that the heart isn't going to be able to pump any blood effectively, right? It's going too fast. So that's why we have to reset that as well.
Right.
All right, that is the EKG component of it, all right? So with ACLS, it's not just doing compressions and hooking up an AED and having it tell us if it's gonna shock or not. Now what we're doing is we're looking at the EKGs ourselves and we're determining the need for shock and the need for certain medications. So we first recognize that someone needs cardiac arrest by they don't have a pulse. We begin doing CPR and we hook up an EKG to them. Through the pads, typically, we can look at these rhythms. If we identify a shockable rhythm, we're going to go ahead and shock it. So those shockable rhythms are VTach and VFib with no pulse. If it's a non-shockable rhythm, then we just continue CPR, but every 2 minutes when we do our pulse check, we'll also check for a rhythm as well. We'll double check the rhythm and see if it has turned into a shockable rhythm or not.
And this is one thing where it's worth mentioning that high quality advanced cardiac life support includes the basic stuff, right? But doing it at the best you possibly can. So like one of the things that really comes into play here is doing chest compressions while the AED is charging, right? So we're like, when we talk about this in BLS, but like you want to be off the chest for the most minimal amount of time possible. So the only times you should be off the chest is when an AED is asking you to be off the chest while it analyzes a rhythm. In advanced cardiac life support, though, you're the one looking at the EKG. You're not relying on an AED. So the only time you're off the chest is for less than 10 seconds to check for a pulse every 2 minutes and when a shock is being delivered. Any other period of time, you should be on the chest. So I get off the chest, we feel for a pulse, we don't feel a pulse, and I say, hey, this is VFib, we need to shock. I should get right back on the chest and do chest compressions until someone has dialed up the pads, is ready to deliver a shock, and then they're going to say off the chest, you're going to take your hands off, they're going to shock them, and you're going to get right back on.
And I think a lot of times with ACLS, people are like, well, this is basic EKG interpretation, and maybe maybe that could be an intimidating topic. It tends to be the most intimidating topic in ACLS is really just identifying EKGs. But people are like, well, I know tachycardia, I just count the waves and it's fast. Yeah, but you need to identify these rhythms in 10 seconds, right? Like that's all we have. So we need to be able to identify the rhythm in 10 seconds and know whether we're shocking or not, or giving a medication or not. So that's the general CPR and shocking component of ACLS cardiac arrest algorithm, right? Now what we can do too is we can start adding medications in. So one medication that we're going to use is IV epinephrine. All right, epinephrine is going to be used in pretty much all cases of cardiac arrest because epinephrine is a beta agonist that will hopefully get the heart beating. It's a chronotropic and it's an inotropic. It's going to get the heart to beat harder and faster. The more epinephrine we give, I shouldn't say it that way, but like we're giving epinephrine in order to get the heart to try to start beating on its own. Okay?
It's worth talking about here too, epinephrine. Currently, we do 1 milligram every 3 to 5 minutes. That is what the ACLS algorithm says for cardiac arrest. 1 milligram every 3 to 5 minutes. Why not 2? Why not 0.5? Why not every 2 minutes? Why not? There is actually no answer to that right now. There's actually a lot of research happening right now to say maybe higher doses. We used to do back in the 80s much higher doses of epinephrine. We used to just stack epinephrine doses and things like that. Then we went down to 1 milligram because research said maybe that would be better. And then it's a 3 to 5 minute range, but like why not just 3? Why not just 5? These types of things. So I bring that up because it's important to know that these things can change. The algorithms do change. A lot of this stuff and the data we're using is the best data we have today, and that could change tomorrow.
And it might not be epinephrine.
Right.
It'll probably always be a big, heart beta agonist, right? But it might not be epinephrine. For a while, we were using vasopressin.
Well, and there's a lot of data to say that in people who get rosk, maybe the epinephrine doesn't actually matter. Like maybe we shouldn't be using epinephrine at all. Maybe we should. I mean, so again, like we're using with the research and data we have today, we're using our best educated scientific knowledge, I guess, right?
Which is why, ACLS is typically a certification that you recertify every 2 years because the science, does the research changes and we get new information. Also understand that when you participate in a code, you're as much a part of the research as you are in part of the treatment, right? So like you are generating research, and once you do these reports and you fill that data out, that goes to organizations that use that as research to determine, okay, did we have good outcomes or could we have gotten better?
Right. Another thing I'll say too with epinephrine. So epinephrine every 3 to 5 minutes, right? When we talk about high quality ACLS, and we're talking about minimizing, time that we're off the chest and maximizing efficiency. If epinephrine is every 3 to 5 minutes and I'm doing pulse checks every 2 minutes, then my recommendation is epinephrine's every 4, because that means that every other pulse check, I'm giving a dose of epinephrine. So I'm getting off the chest. While I'm checking for a pulse, someone's pushing epinephrine. I'm reading that rhythm. I'm immediately back on the chest. I'm shocking or not shocking. I'm doing another 2 minutes of CPR, and then I'm off the chest again checking. And because what happens, I've seen this happen in codes where, people are doing 3 minutes, people are doing 5 minutes. They're trying to time it. Maybe they're off here or there. So we're giving epinephrine at random times. And then we give a dose of epinephrine, but then we don't know if we've got a pulse back. And then, do we need to circulate that epinephrine? All these questions arise. That just complicates it. Keep it efficient. You should be pushing epinephrine every other pulse check.
Right. And that's so simple. Everybody has something to do in part of your team. Let's say you got a 4-man team. You got someone who's on the chest. You got someone who's swapping off with someone on the chest. You got someone who's managing the IV, and you have someone who's managing the airway. That would be ideal, right? At least those 4 people. So you've got everybody has something to do at that 2 minutes. The chest person switching with the other chest person and reading the rhythm and ready to activate the AED. The airway person is holding ventilations for a second so that we can check the EKG and make sure that we're good there and running the code. And then the IV person is pushing the meds that they've prepared in the 4 minutes that they've had to prepare those meds, right? So that's a big part of team dynamics, is a big part of ACLS, and ensuring that this stuff, not just like perused it and understand it. This so intimately that you can operate in any aspect of that team, and that your team can as well. And you're able to do this under pressure and in seconds, not minutes. So another med that we may give in shockable rhythms is an antidysrhythmic. And this can be given right after epinephrine. It can be given with epinephrine. It can, it's going to be given IV. And right now, the antidysrhythmic of choice in the field is amiodarone. Amiodarone, it acts as an antidysrhythmic. You can kind of think of it as a synthetic way of delivering a shock to the heart. It does the same thing. It helps get rid of those ventricular rhythms and encourages an environment for normal organized rhythms. So in our VTACs and our VFibs that are pulseless, we'll also be giving amiodarone. So you're not just checking that EKG and confirming that it is a shockable rhythm for the shock. You're also confirming if we're going to use an antidysrhythmic medication too. And we're talking about very basic codes. There are certain codes that you might need to do. For instance, you might see a special rhythm called torsades de points where you need to give mag sulfate, and there's other. We're going to talk about sort of basic common codes in this one, just because we can't cover every aspect of ACLS in a short period of time.
And that amiodarone, because we're doing electrical shocks to the heart, we don't really need that amiodarone immediately. We typically reserve that amiodarone for when we have what we call essentially shock-resistant VFib or VTAC. So when we've shocked the heart a third time, and that's when we push amiodarone in an ACLS algorithm. Mm-hmm. So we're not doing it with epinephrine immediately. We're doing epinephrine every other pulse check. We're shocking every pulse check if we need to. And if we get to a third pulse check and we are still seeing VFib or VTAC, we're going to push amiodarone then.
Yes, correct. And then the other part of advanced care that we haven't talked about too much is obviously you need to be able to get IV access to push these IV meds. You can also give them technically like interosseously if you have a bone drill and you need to drill into their bone because you can't get IV access. But you need to get these medications. Some of these medications can be given down the tube too. But that's the other big component. This is airway management, right? So in a cardiac arrest, we want to have an advanced airway in place. Now that could be intubation, that could be a supraglottic, that could be an LMA. But we want to have as advanced as we can get, as quickly and effectively as we can get, so that we can oxygenate the heart as well.
And without disrupting the other components of cardiac arrest. So we talk about this all the time, like we should not be holding chest compressions to put in an advanced airway, right? We should attempt if we can, but But again, if we can't get one and you're like, oh, well, maybe if they weren't doing chest compressions, I could, well, too bad. Chest compressions are more important.
Right. And we can, that might stop us from intubating, but you can put in an advanced airway that is supraglottic, like a King tube, a combi tube, or an LMA. I mean, you can put those in without needing to visualize the cords and needing a laryngoscope. So if you can't get it after 2 tries, put a supraglottic in, right? Like we don't have time to kind of like mess with egos here or, get the perfect, we're not going to always going to intubate. It's not necessary in that situation.
Yeah. And ideally, as I said, when we're talking about super efficient, high quality, top of class advanced cardiac left support, we want an advanced airway. Because once I have an advanced airway, now I can just breathe for the patient every 3 to 5 seconds, right? So I can just I don't have to wait for breaks. If I don't have an advanced airway, then I have to be doing this 30-2 ratio, right? Which is what? Time off the chest. Every time we pause for 2 breaths is a pause in the chest. We want to be able to get to the point where we're just constantly doing chest compressions and bagging the patient at a normal, regular rate.
Right. And we talk about in our BLS lecture, there's also gastric distension risk with basic airways with BVMs. There's a plethora of things, that it's obviously a larger advantage to have an advanced airway in place with capnography attached in order to measure that. Yep. So, you want to talk about team dynamics quick?
Yeah, so we touched on it a little bit just a second ago, but the team dynamics is a critically important point. Now, I recognize that many of you work on the back of an ambulance with 2 other guys, maybe 1. A lot of you work in ERs where you're understaffed and you don't have the... Ideally, though, when we talk about the highest quality, is there should be a team of 6 people for every code, right? There should be a team leader. That's usually the most advanced person there. I myself, as a physician, as an emergency physician, will typically take that team leader role. There should be someone doing chest compressions. There should be someone monitoring the airway. There should be somebody doing IV access and pushing medications. There should be somebody essentially managing the monitor, right? Delivering the shocks and that sort of thing. And there should be someone recording the event, all right? Ideally, we have 6 people there. There's actually a push now. I think ACLS recently redid their guidelines where they also have like a watcher now, someone who's like watching the chest compression person to so that the team leader doesn't have to focus on chest compression. That was new.
Yeah, I just kind of think that at some point, if you're running the AED, you have nothing to do for 2 minutes at a time. Right. So you're watching the compressor and you're going to be the person that swaps with that compressor anyway.
Right,
right.
I mean?
So, or if you have a Lucas device in place or something like that, you don't have a compressor because you have a robot. So you're just managing that in the AED.
Yeah, exactly.
You can, from the paramedic side, you can run a code with 2 people. Ideally 3,
right?
But you can run a code with 2 people.
Yeah, I think I still like the highest quality efficient ones are calling for 6 people in this regard. A couple of things I'll talk about there. This is why clear communication is such an important part of advanced cardiac life support, is because I need to be able to articulate what my role is and understand what everybody else's role is as well. As a team leader, I used to encourage people all the time. I wouldn't even put on gloves if you're a team leader, because what happens is as soon as I put on gloves and someone's having trouble with the IV or someone, we needs a pulse check, I have a tendency to want to get involved and I immediately can lose sight of what my job is, which is to oversee the whole thing, right? So communicating roles really, really well, that kind of back and forth communication. When I say push 1 milligram of epi, the nurse says back to me, all right, that's 1 milligram epi. You want me to push now? Just in case there's mistakes. Yeah, the closed loop communication part is critically important.
Yeah.
Really quick, the Lucas device. So now we have these compressive devices that we can put on patients that do the chest compressions for us. I've seen a lot of people kind of snub their noses at them. The research shows that they're way better. Yeah, they are way better than us doing chest compressions. The other cool thing is that the monitor can read underneath the Lucas device most of the time. So I can shock a Lucas device. So again, when we talk about time off the chest with a Lucas device, I might turn it off to read the rhythm, but I turn it right back on and I can deliver that shock while it's still going. And I should if I'm going to do that, right? I don't have to get off the chest to deliver the shock so I don't get shocked. The Lucas device can take the shock. It's perfectly fine. So these Lucas devices are incredibly important augmentation pieces. They're expensive, which is part of the problem, but huge aspect to making sure that we're doing high quality chest compression throughout a code.
Absolutely. So one thing, last kind of part of a cardiac arrest code that we want to pay attention to is basically reversible causes. So we're treating the cardiac arrest in the sense that we're trying to resuscitate, but there might be an underlying condition or something that caused this cardiac arrest that may have a common or quick fix that we can get to. And that's what these reversible causes are are designed to kind of help you with the 10 most common reversible causes of cardiac arrest, so that we can also do kind of that adjunct treatment. Otherwise, what happens is we get so caught up in this rhythm of 2-minute codes that we never really think outside the box and start thinking, well, what could have caused this? Like, is their sugar low? Should I have just maybe given them sugar as well? And could that have helped? So we called the reversible causes the 5 H's and the 5 T's. And the H's are hypoxia. So if you have, I'm going to say the cause, you tell me the solution.
Okay.
All right. Hypoxia.
Oxygen.
Give them oxygen, right? Hypovolemia.
Fluid resuscitation. So this is where fluid resuscitation could become an important part of your code. If you have, a history or a reason to think that this person was extremely hypovolemic, or blood loss as well. Hypovolemia from blood loss. Well, now I need to be giving a rapid blood transfusion at the same time I'm running a code, because guess what? A heart that's pumping that doesn't have blood to pump is not really helping anybody, right?
Exactly. The hydrogen plus ion, right? So this would be acid. This refers to acidosis.
Right, so acidosis. So this is where we may consider things like sodium bicarb, and even that the research is really still out whether or not that's really beneficial in the code. But when we're looking at like truly reversible causes, I know this patient's supposed to be in dialysis. They missed dialysis for 3 weeks. Like maybe they're super acidotic. Okay, maybe I might push some sodium bicarb and that sort of thing.
And I think that's a perfect example of like, if I'm not trained to consider the H's and T's and that's not shoved into the algorithm, like when you're running a code, you're not thinking about, oh, hey, did they get dialysis? You know what I mean? Like, unless that's written in there, which is why this is really, really important aspect of the cardiac arrest algorithm, because it makes us think outside the box and get a little bit of a wider lens on the emergency. So next one would be hyper or hypothermia.
So maybe hypothermia in this case, but like there's this old adage that like you're not dead unless you're warm and dead. So if someone's like super hypothermic, like we need to warm them up as well, because that can obviously disrupt the electricity in the heart. That can disrupt just blood flow. Hyperthemia as well, though. I mean, someone's like cooling them down with like cool fluids or bladder irrigation, ice packs to the armpits and groin and things like that. If they, is also something to consider.
Yes. Hyperkalemia is the last H.
So hyperkalemia is, again, this is weird because it's kind of the same as the acidosis a little bit type of thing. So in hyperkalemia, though, if we want to, what's that? You have high potassium. So you may be considering giving things like
potassium.
What's that?
Potassium.
No, they have hyperkalemia. They have too much potassium, which causes like an acidotic type of thing. So like,
it's just, don't you just have to give them fluid to flush it out? Like,
give them fluid. I think you can do sodium bicarb again there too and stuff like that. But
typically, you'll see on the EKG, you'll see like peaked T waves if you have really concerning hyperkalemia. That one's, I would say, pretty rare. The T's, tamponade. So cardiac tamponade. So
cardiac tamponade is where you have blood in the pericardial sac pushing down on the heart. So if you think someone has cardiac tamponade because maybe you have an ultrasound at bedside or because of mechanism of injury with trauma, a pericardiocentesis, you have to like literally stick a big long needle up through their xiphoid process to try to penetrate that pericardial sac and pull that fluid off the heart or around the heart.
And we cover cardiac tamponades in one of our other podcasts.
Do we?
Yeah.
No, cool.
Remember we did the whole weird like...
Oh, yeah, you're right. That was a good one.
Yeah. Okay. Tension pneumos. We definitely cover this in one of our podcasts.
So tension pneumothorax, collapsed lung, right? There's air, just like there was blood outside of that pericardial sac in cardiac tamponade. Tension pneumothorax, there's air trapped inside the chest wall cavity pushing the lungs down. Kind of goes back to hypoxia, right? I can give them oxygen, but the lungs collapse. It's not going to do anything. So I got to maybe put in like a chest tube to be able to pull that air off so that the lung can reinflate.
Or just pleural decompression if you're in the back of an ambulance and you don't have access to a chest tube.
Yep.
Then there's the two thromboses that you could run into. So a coronary thrombosis, basically they had a heart attack.
Right.
Or a pulmonary thrombosis, they had a PE.
Right. And for both of these in the acute setting, we're going to potentially consider like alteplase. So you're going to consider essentially a clot busting drug to try to break that clot up so that you can get flow again.
Yep. And then last T is toxins.
So toxins, so like overdoses, like chemical toxins, medication toxins, overdose, an opiate overdose. Maybe they need maybe we're going to throw some Narcan in there to try to like reverse the opiate effects. Trying to think of other kind of like common toxins in that way. Carbon monoxide, maybe we're going to do, obviously oxygen therapy, but consider things like, or if you're worried about, maybe like, what am I trying to think? Cyanide, things like that. Like we're starting to think about these things. Like, do I need methylene blue? Do I need like these different like random things to reverse, different toxins as well?
Yeah, and I think that's an interesting point. Like take the instance of an opioid overdose, right? So they died from cardiac arrest. They died from cardiac arrest from respiratory depression. They died from cardiac arrest from respiratory depression from an opioid overdose, right? So like it's bringing that chain back and saying, did they die from an overdose? Sure, but they ultimately die from cardiac arrest, understanding that chain, and then where can I interrupt that chain? Well, the CPR isn't resuscitating them. The oxygen doesn't seem to be resuscitating them. Oh, I can reverse these opioid receptors. Now they don't have respiratory depression. Now my treatments are helping. Exactly. And it's thinking of that wider lens that's going to help us a lot. So that's great. That's cardiac arrest. Now we have like 5 minutes here to cover rosk. Okay, so we bring them back. How do we know that we brought them back to life?
So 2 things. You either feel a pulse or you see a spike in your capnography reading.
Right. Only 2 things that will identify that someone is alive. Okay, so you either feel a pulse in your pulse check or you see a spike in their capnography. Hopefully then you can still confirm with a pulse check and feel their pulse. There is a chance that they're a larger individual, or if they have a very weak pulse rate, maybe you still can't palpate it. But that capnography and that pulse is the indicators that somebody is alive.
The first thing you then do is get a set of vitals.
Yeah, try to get a blood pressure on them.
Yeah, because there's 4 main things we're going to look at in return of spontaneous circulation, right? It's going to be their blood pressure, their oxygen status, their temperature, and then again, reassessing their cardiac electricity, okay? So the first thing we're going to look at is a set of vital signs. What's their blood? Do they have a stable blood pressure with this pulse? Maybe this is too weak of a pulse. They've got low blood pressure. What am I going to do about that? Maybe I'm going to give pressors. Maybe I'm going to give fluids, right? We need to start doing that. Them, right? Yeah, maybe they need to be paced because they're in a super bradycardic rhythm. So I need to, like I said, is their blood pressure stable? And if not, I need to treat that. I need to get that blood pressure up so I can oxygenate and perfuse the tissues, right?
We usually want to see something north of 90 systolic.
Yes.
If we can get north of 90 systolic and maintain that pressure, that's great. Like Chris said, what's causing that hypotension, right? If it's bradycardia, then pacing. If it's an issue with contractility,
hypovolemia fluids, right?
Yeah, if it's a contractility issue or just a pressure in general issue, I might consider, like a catecholamine drip, epi or dopamine.
The next thing is going to be oxygen, right? We're going to titrate their oxygen from 94 to
93. 93 is the cutoff. So
93
north of
99. And I say 93 to 99, and here's why. If I oxygenate you at 100%, I don't know when you start to decompensate. So really quick, if I put you on a non-rebreather and you're at 100%, but you only needed 4 liters of oxygen, right? But I gave you a non-rebreather, you're at 100%. Now you all of a sudden need 6 liters of oxygen, but I got you on a non-rebreather, so you're still 100%. Now you need 8 liters, but I've got you on a non-rebreather. Now all of a sudden you need a non-rebreather, but I already got you on a non-rebreather. Now you need more than a non-rebreather, and this is the first time I'm recognizing that you're decompensating. So the reason I tell people titrate from 93 to 99 is because if you can get someone down to 2 liters of oxygen and they're at 98%, but all of a sudden they're at 92% and you've got to titrate that up to 4 liters, 6 liters, you know that there's something going on and you're recognizing it earlier on.
So yeah, so those are kind of the 2 vital signs that we want to manage, that we take the most concentration on when it comes to post-cardiac arrest care. The other 2 things that we want to pay attention to is we do want to run a 12-lead EKG. So if you go back to that picture where we saw just a view of the heart from that bottom right side, the bottom right of our picture, where we're looking at an EKG, what a 12-lead EKG allows us to do is to look at 11 other angles, right? So we get a bunch of different angles of this heart, and that can tell us if there is blockage, and we'll talk a little bit more about this when we talk about STEMI identification in ACS in part 2, but this can tell us if there's blockage in the heart, if there's death of heart tissue. This can also tell us, are we sure about these rhythms?
Are we too fast? Are we too slow? You know what I mean? That's where we get into the other algorithms with tachycardia and bradycardia.
So 12 leads, the idea behind that is more is better. Obviously, 1 view of the heart is great. If we can get 12 views of the heart, that's even better, so we can look at kind of different areas, and you can pinpoint different pathologies with a 12-lead EKG. So it's important to get a 12-lead post-cardiac arrest. And then we also are concerned basically about the metabolic strain on their body. So they have been dead. They've been in anaerobic metabolism without any oxygen. And that's going to create a lot of byproducts and toxins in their body. In order to remove those toxins, the best environment to remove those toxins and help the body repair and flush that out is a cold environment. So we will consider cooling the body between 32 and 36 degrees Celsius. And we'll do that with cold IV fluids. We'll do that with, what else do we, that's pretty much it, right?
Put big catheters in and can do, run cooling, that sort of thing. Cool, they've got blanket things that cool people down.
If we can cool that core temperature down, it basically slows the metabolic process and allows our body to be able to, and us to help kind of clean that body out of those toxins. And research has shown that we have better outcomes if we can cool. Yep. Now, there are some cases that cooling is not an ideal depending on the pathology of the cardiac arrest, like why they went down. But for the most part, cooling is an ideal situation.
And we usually tell you, consider temperature management, right? Like your hospital or where you're taking the patient, if you're in EMS, they're going to have temperature management processes. So consider that and engage those right away to get that going if it's important.
Yeah, if you rescued me from drowning and then you did CPR on me and I cough up water and then I start talking to you and I'm like, oh my gosh, thank you so much for saving me. Don't insert a cold catheter and cool my core temperature and put me into a coma.
Exactly.
So all right, so that covers 2 of the 6 algorithms for ACLS. You can catch us in part 2 where we're going to cover bradycardia, tachycardia, acute coronary syndromes, and acute ischemic strokes. They should be a little bit faster than this one. This was kind of the big, intimidating one. So we are pretty much halfway there, even though we're only 2 out of 6.
All right, cool.
We'll see you next time. Stay sweet. All right, welcome back. This is ACLS Part 2. We're not going to do an intro because we're going to just jump right into it. We covered in ACLS Part 1. If you haven't watched that, what are you doing?
What am I doing? What do you mean, what am I doing?
No, I'm saying, if you haven't watched that, what are you doing, audience?
Yeah.
Honestly.
You just picked Part 2 from the beginning? Idiots.
Well, and you don't want a whole look at ACLS. You only want to solve bradycardia, tachycardia, strokes, and heart attacks. What if they die? What if they die?
Just knock it off.
Stop it.
Okay.
So anyway, ACLS Part 2, we covered in ACLS Part 1.
Now that everybody's not listening anymore. Just kidding.
We covered in ACLS Part 1, we covered rosk and we covered cardiac arrest.
Correct.
That's it, right? Yes.
Yeah.
And so now we're going to be covering tachycardia, bradycardia, acute coronary syndromes, and strokes. The other 4 topics in ACLS.
Mm-hmm.
With a quick review, we will talk about EKG reading one more time real quick, and then we'll jump into stability identification, because that is an important part of kind of understanding ACLS. Because what happens is a lot of times these algorithms sort of split depending on if the patient is considered to be stable or unstable. So we'll chat on that.
And defining stability and instability is very, very important.
And we have a whole podcast on that.
We do. But in ACLS specifically, there are certain measurements and metrics and things that we look at to define whether someone's stable or unstable. Yes. And there's always, though, because obviously if you think about it, stability and instability is somewhat subjective and not always just completely objective. There's objective parameters and then inevitably always one piece that's use your judgment. You know what I mean? So anyway.
Okay, cool. So let's jump back into it. Reminder on the EKG here. We look at basically 5 things when we're reading an EKG. The first thing we look at is the rate, and the way to calculate that rate is to count the QRSs. This is going to be important because you're going to need to know if the rate is fast or slow to identify tachycardia or bradycardia, right? Mm-hmm. So first we look at the rate. Then we're going to look at the overall rhythm to see if it's regular or if it's irregular. So basically, are those QRS points, so are those R waves lining up appropriately? Is the same distance in between 2 R waves? If there's not, then we know that the heart might be skipping a beat. Maybe it's beating too early or too late, and it's not beating in rhythm, in a solid rhythm.
Maybe it's not coming from the right, maybe the electrical stimulation is not coming from the right place, right? Maybe it's not the SA node, it must be somewhere else and that type of thing.
Or maybe it's multiple places at once, like a PAC, a PJC. Mm-hmm. Then we look at P waves to see if the sinus is responsible for the SA node or the atria of the heart is responsible for beating that. Because if we see a positive P wave, we know that is an atrial rhythm. If we see a negative P wave, we know that's a junctional rhythm. If we don't see a P wave, then it's either junctional or ventricular. Mm-hmm. And this is review. Then we're going to look at the QRS waves to see if they're wide or narrow. A wide QRS wave would be indicative of either a ventricular rhythm or something like a bundle branch block or something that's causing the stimulus in the ventricles to take more time depolarizing. And then lastly, we look at the ST segment. And basically, we'll get to this with ACS, but this is identification of STEMIs or nstemis. The ST segment can show us if we see elevation there, elevation of the J point, we will see that it gives us some evidence towards there's potentially a more serious heart attack happening. And we can talk about why that's more serious and physiologically what's the difference between an nstemi and a STEMI, and we'll get there. So those are the 5 things: rate, rhythm, P waves, QRS, and then ST segment. If you read every EKG that way, from now until the end of time, you will be able to identify 99.9% of all rhythms and weird things that can happen in your heart. So,
and as an ER physician, there's actually like a 6th step, right? So I look at the rate, I look at the rhythm, I look at P waves, QRS waves, ST segment, and then I call cardiology. And at that point, I've covered my butt.
I will say, Chris and I spent some time in the ER together when I was in. Well, when I was in school and he was in the beginning of his residency, and then when he was towards the end of his residency and I was transporting to him, we spent a lot of time in the ER together because I would transport over to him. But I remember like plenty of times I'd like ask EKG questions and stuff just about some like nuanced stuff. And I remember one time you being like, dude, let me just show you something. And you brought a stack of EKGs. Yep. And I swear to you, by normal standards, every single one of these was a STEMI.
Right.
There was ST elevation in terms of like there was ST elevation, and we also knew that there was symptomatology that told us that there was chest pain and stuff like that. So it's a STEMI, textbook STEMI. And you were like, these are all the ones that cardiology sent back to us and said aren't actually STEMIs.
Yeah, right.
So, and we'll talk about this in a little bit when we talk about ACS, but it's important to remember that STEMI is like a criteria of basically like flagging something for us to look deeper at. Just because someone has ST elevation on the monitor doesn't necessarily mean that they're definitely having a heart attack, and physiologically that all adds up. It just it increases our...
It's another tool. It's another tool in your toolbox, right? So I feel like a lot of times, and I even felt this way coming up as a medical student, as a resident, even probably as an attending for a while, like that EKGs were something that you could read and completely diagnose from. And they're really not. They're one other tool that you can use to increase your suspicion or decrease your suspicion for certain conditions. But it's one piece, right? You cannot take a piece of paper with scribbles on it and like diagnose, treat a patient, right? It is a part of it. Just like you can't take one blood pressure reading or one heart rate or, you know what I mean, like one blood sugar measurement and treat a whole patient, right? It is one thing you have to look at. And there is some art and science to it. And the art part of it is that sometimes, even though it looks a certain way, you look at the whole thing and you look at cardiology and 5 people think 5 different things and you go with the best, the best one you think is.
Yeah. The only real definitive way that we know that someone's having a STEMI or a heart attack in general is being able to like look in there and see it. Right. So it's similar to, if you had, we know that when someone's having a PE, a lot of times their SpO2 saturation drops. That doesn't mean every patient that has a low SpO2 saturation is having a PE, right? So just another piece of data to help increase our suspicion for certain conditions.
Right. And when it comes to STEMIs, and we'll talk about it with acute coronary syndromes, the purpose of the EKG is to help us figure out if we're going to go look or not, right? I mean, if we're going to actually do that cardiac cath and go look, because that in and of itself is an invasive procedure. So like, we don't want to do that necessarily on everybody. So how do we know who we should do it on? And like, again, one of the tools you have in your toolbox.
You want to just talk about ACS first?
Let's do that.
Let's just do that. We've already kind of built it out. So
I like it.
So yeah, and then the other thing that I want to add to that is, because I saw this all the time in the field, I see it all the time in the hospital. Like, do not let the end result affect how you've learned to identify this stuff.
100%.
Right? Because what happened all the time is the medics that worked with me would basically, if they saw a STEMI, they saw ST elevation on the monitor, and the patient fit the criteria. They had chest pain. They, maybe even they had a history for cardiac issues, and they called a STEMI code. So they called and said, this is a code STEMI. This is a STEMI alert. Anytime that ended up not being confirmed by they go in to put a stent in and they confirm that it's not actually a STEMI, that would disappoint the medics I worked with so much, and they'd be so discouraged about it. And it was sort of like you're
I was wrong.
Yeah, you're darned if you do, you're darned if you don't, right? But like, that shit shouldn't happen.
No, you weren't wrong. So this is the thing, is that there is a difference between interpreting an EKG correctly and what that outcome becomes, right? So if you look at an EKG and it meets criteria for STEMI, and you call a STEMI, and a cardiologist down the line says, no, I disagree, or they don't, or they go to cath lab and there's no blockage there, you weren't wrong about that EKG, right? It's like looking at a heart rate and saying that's tachycardic. And then later someone saying like, oh no, this patient doesn't need any treatment for that tachycardia, that's their baseline. You're not wrong that it was tachycardia. There are criteria for that, right? So, and that's something in medicine in general we have to be super careful about, is that letting the outlier outcomes change how we practice the basics of medicine, right? And I used to see this all the time. And there was a case specifically where one of my attendings when I was in residency, I got an EKG. It showed, I'm trying to remember exactly the case, but it was something where like the EKG showed some like tachycardia. And the patient didn't meet criteria for like a PE, but the attending was like, oh, but one time I had a patient who was tachycardic and they did have a PE. So now I scan every single person who's tachycardic. Yeah, like you can't do that.
So that's the other thing, is the reverse is true too, because then you'll have some medics that won't call a STEMI ever because they're worried about calling a STEMI and being quote unquote wrong about the end result, right? And then you have some other medics that always call a STEMI because they figure, oh, I'll just catch it. You know what I mean? Why not?
Even if it doesn't meet criteria,
STEMI, right? Yeah. And you can't do that either, right? Because that harms the system. But what's really important here to fix these communication issues is to, if you work in the ER or you work in cardiology, you work in the hospital, and you're interacting with the people that are responsible for, calling the initial STEMI alert, even if it doesn't turn into a STEMI, you need to kind of give those people an attaboy of, hey, no, you did the right thing. You definitely, yes, they fit the criteria for it. It didn't end up being a thing, but this is why that criteria is in place. And if you don't feel that way, then the criteria needs to change.
Yeah,
and,
right.
And that's on you. You know what I mean? That's on the hospital and on the research system and what we're using to flag. But never discourage someone from using the identification tools that you've instructed them to use to identify something, right?
Exactly.
So anyway, that's my spiel about identifying STEMIs. So just don't ever be afraid. If you think that it's a STEMI, call it and give that report, right? And here's the thing too, is you're sending the EKG to the hospital anyway, right? So they're going to get a look at it as well. So you're not technically, when you call a STEMI alert, saying this person is having an ST elevated myocardial infarction. You're saying this person meets the criteria because I see ST elevation. So if you just say in your report, I see ST elevation in 2-3 and AVF, that's all you got to do, right? They can confirm that.
Same for me as an ER doctor too. I don't cath people. Right? So when a patient comes in and you show me that there's a STEMI and I look and I say, there's a STEMI, and I activate the cath lab and I do all the things, if the cardiologist doesn't want to take that person to cath lab, well, that's on them. It doesn't change the fact that I need to activate that system because, you know what I mean? So, and unfortunately, we do see that a lot. Yeah. And if you look at ACLS guidelines, and I don't believe this has changed anytime soon, but if you look at ACLS guidelines, technically, any person who meets criteria should be cathed every single time. Now, the system doesn't work that way because cardiologists get bad outcomes if they cath people who die on the table. There's a lot of like politics and also like just kind of like nuances there. But if you look at the actual guidelines, really like everybody should be cathed if they meet criteria.
Well, because the cath is not just the procedure of like stenting someone, it's the visualization of the issue too. So they have to, the catheter is used to go in and look in the first place. Right? Yeah. Okay, cool. So let's break it down to basics a little bit and go real basic with what acute coronary syndromes are. So acute coronary syndromes, coronary is referring to the coronary arteries, the vessels that supply your heart with blood. When we have an acute coronary syndrome, we basically have a lack of blood supply to the heart muscle itself, right? And this can be caused by a couple things. It can be caused by a narrowing of the vessels.
Constriction.
Yeah, so
not a blockage necessarily, just constriction of it.
And that constriction can be from spasm. That constriction can be from, I have too much plaque buildup. The plaque doesn't even have to rupture. It swells, right? It can be from inflammation. It can be from, I guess Prinz metals would be like a spasming. So So the couple ways that it can constrict, right? It can be from a blockage completely, where maybe a piece of plaque breaks off and then blocks it. Maybe
which is an embolism, right? A piece of plaque. It's a foreign entity like breaking off, traveling to an area and causing a blockage.
Right.
Or it can be thrombotic, where it's just that plaque gets bigger and bigger and bigger until it just blocks that area, right? It doesn't break off and travel somewhere. It's just right there, but it gets bigger and bigger.
Yeah, it can be a result from our clotting cascade in general. So it can be our attempt to stop a bleed. The clot becomes too big and basically scabs over and blocks that vessel. And then you can also get acute coronary syndromes from things like bradycardia, right? If my heart is beating too slow, I'm not getting enough oxygen to my heart to continue to beat. So there's lots of ways that you can have lack of oxygen to the heart.
So there's a couple different acute coronary syndromes, right? So and we define them based on what the mechanism is for that lack of oxygen to heart tissue, right? There is unstable angina. Well, I guess there's angina.
So you, in recent years, have been saying angina, all right? And
I don't like saying angina.
Is it just because you don't like saying it? Because it can be pronounced either way, correct?
I think it can be pronounced either way. I don't like saying angina.
I like angina.
I don't like.
No, I wasn't trying to be. I wasn't even trying to be funny there. And I realize I'm hilarious all the time, but I do like that pronunciation better. Angina to me sounds weird.
Okay. Well, you can have. How do you want to say it on the podcast? Then we got to pick one way to say it. We're just going to confuse.
We say angina.
All right, fine. I don't like it though. So anyway, you can have.
Here's the thing: if I take a clip from this and I say angina, and I take a clip from that and I put it on TikTok, maybe TikTok reads that word wrong, and then the views of that video goes up higher
because people are searching things that are like angina.
I honestly think that. So there's a TikTok that we had that has over 500,000 views. And I think it's just because I said the word nipple in the video because I was talking about the nipple line.
Yeah, probably.
So I'm just saying.
Just keep saying
to our strengths. Yep. Angina.
All right. So anyway, acute coronary syndromes, you have angina, you have unstable angina, you have stemis, and you have nstemis. So ST elevation myocardial infarctions and non-ST elevation myocardial infarctions, which are really one thing. It's myocardial infarction. Yeah. But again, there's like technically 3, right? Or is there more than that? Those are the 3 that we typically define within acute coronary syndromes.
I mean, you named 4. Unstable, stable.
Well, I'm saying it's angina, unstable angina, and myocardial infarction.
Yeah, essentially, when we're talking about ACS, we're talking about chest pain protocol. Yeah. Just chest pain protocol in general, right? So,
but angina is basically lack of oxygen to the heart tissue that can cause symptoms, but it doesn't cause irreversible damage.
Correct.
It doesn't, no tissue dies.
Right.
Unstable angina is where that's happening, like even at rest. Which is, so like angina is where, maybe you exert yourself, you snort some cocaine, I don't know, whatever you're into, and you get chest pain symptoms. You get symptoms of lack of oxygen to the heart tissue, but there's no reversible damage, or there's no irreversible damage, excuse me. Unstable angina is where you're getting those types of symptoms even at rest, which is a problem, right? Because it means that there's enough of a constriction or enough of a potential blockage that like we could be heading towards a more serious event if that's left untreated, right? You can stop snorting cocaine. You can't really like make your plaque smaller. You actually can. That's a whole different story.
So unstable angina though, like at rest, stable when I'm running or I'm exercising or something like that, it's still a precursor to, there's a lack of health here that we need to adjust.
There's still acute coronary syndromes.
It's obviously more serious if at rest, when my heart rate is as slow as it can be and I'm as calm as possible, I don't have any adrenaline running through my system, I'm still hurting, right? And It's not going away.
Right. So, and then myocardial infarction, and the key word there is infarcted tissue, dead tissue. So there's been enough of lack of oxygen to the heart tissue to cause death of tissue, right?
So there's the difference between ischemia and infarction, right? Ischemia is just the lack of oxygen. That's going to happen. And every myocardial infarction will start with angina, right? Yeah. So first you'll have the ischemia, and you may or may not be symptomatic with it. Symptoms will start to develop as you have that lack of oxygen extend for a long period of time. And then eventually that heart tissue will start to die or infarct. And it'll die in a bullseye-like pattern based on where the blood is supplying, right? So right in the area that where the blood hits the most is what's going to start, dying first.
Right. So the other thing too is, and this is a generalization, but that's what we like to do here, is back to basics, kind of generalization so that we can wrap our minds around this stuff. Stable angina, right? To your point, I start running a marathon or I start just running across the street and all of a sudden I start having chest pain. We typically treat that with symptomatic treatment and lifestyle changes, right? You've clearly got plaque buildup, or we do some tests to see if you have plaque buildup, right? And we say, okay, so we're going to change your diet, We're going to put you on antihypertensives, antiplatelet drugs, aspirin, things like that, right, to try to make that better. When we get to unstable angina, that's where like these symptoms are happening at rest. I'm getting chest pain when I'm sitting watching TV. Those patients typically need a cath at some point. They may not need an emergent catheterization, but they probably need a catheterization and some type of stent, because like we're not going to probably reverse that soon enough with the lifestyle changes and medications that we could.
And a stent or a cath is opening that vessel up. So mechanically going in and putting in like a mechanical mesh to reopen up that vessel and expand it so that we can get better blood flow.
Yep, exactly. And then myocardial infarction obviously needs a stent or a cath. Right? Those need to be opened up more emergently because that tissue's dying and will continue to die if left untreated. Super interesting, actually, and I don't think this is talked about enough, so I'm going to give a little side note here. There have actually been studies, and I think these studies were done like in the 90s, but like there have been studies of people who had cardiac cath confirmed plaque buildup in their vessels who went on plant-based diets and then got recathed after, I don't remember exactly how long, but got recathed after like a year or something like that, and no longer had plaques.
Yeah,
which is kind of crazy.
You can
actually reverse plaque buildup. We don't talk about that enough. That's crazy. I didn't know that until I was like an attending physician. I thought like once you had plaque, like you kind of had that plaque and you just tried not to get more.
Yeah,
you can actually reverse it, which is crazy.
Unclog your arteries essentially, which is pretty cool.
Yeah, which is crazy. So, but who wants to?
Yeah, not worth it.
No, not
Cats
worth
aren't that expensive. Just kidding. So that kind of describes the two conditions. We're dealing with ischemia or we're dealing with infarct. The thing is in the field, if you're EMS or if you're noticing this on the nursing floor or anything like that, it's still going to be like a rapid call or a high priority patient. Like we have protocols on my nursing floor that if you have someone who has chest pain that doesn't go away with rest, that's like you're going to call for a rapid response. So you're going to have the RRT team come and examine that patient because it could be something very serious. There is no way symptoms-wise to determine whether or not someone is having an infarct or if they're just having the ischemia and the angina, right? So what we have to do is we have to treat all these patients the same in terms of our emergent immediate treatment. And that is where the MONA protocol comes in.
Are we still using MONA across the board?
Yeah, sometimes it's FONA. Sometimes it's basically you're going to be using analgesic with oxygen, nitro, and aspirin.
All right, so for the sake of this, let's talk about MONA, right? So MONA, M-O-N-A, you've got morphine, oxygen, nitroglycerin, and aspirin. And each of these is doing something a little bit different.
And they're not done in that order, which is weird. We just try to make it sound cool, like MONA. Like I guess that sounds more like a name.
Mona Lisa, probably.
I guess.
I don't know.
You know, Mona Lisa could have been... I'm not even going to get into it. I read the Da Vinci Code series recently, so probably none of it's facts.
No,
but no, a lot of people think that Mona Lisa might have been a self-portrait of Da Vinci in drag.
Oh, that's cool.
Isn't that weird?
I guess.
Is it cool?
I don't know. That's what I'm saying. I don't know really how I feel about that. Yeah. I want someone to have caught Da Vinci doing a self-portrait in drag, who like walked in and be like, "What are you doing, bro?" You know? Anyway.
Something to think about.
We digress. So MONA, morphine, oxygen, nitro, aspirin. We don't do them in that order.
We start with oxygen, right? We have lack of oxygen in a tissue. What do? We're going to give them oxygen.
Exactly.
Pretty simple. And we're going to titrate. Chris and I always say titrate to 99% because that way you'll know if they decompensate faster.
Correct.
Right? That's all we're going to say on it. You can look up our other videos to figure that one out.
Aspirin.
Aspirin is an antiplatelet. It is not a blood thinner.
Correct.
It prevents the platelets from being sticky, which means it's an antiplatelet, and therefore loosens up.
It just prevents further plaque buildup.
Further clotting. So it's not a clot busting medication. That's called fibrinolytics, right? If we gave fibrinolytics or thrombolytics, then we would be busting a clot that's existing. The aspirin is just to make sure that now that the heart is under extra stress, that we're making the platelets a little less sticky so we don't propagate the current clot if it's a partial clot in a vessel, and we're not going to have any more clots while the other vessels are under stress, right? Nitroglycerin is a medication that expands coronary vessels. And we talked about this recently. There's a TikTok that went out that was kind of big about nitroglycerin because I compared it to Viagra or Cialis. And there is truth to that. Absolutely. Viagra and Cialis were both attempts to make a version
That's
of
how
nitro.
we found nitroglycerin for chest pain, is that people were trying to use medications to treat erectile dysfunction, and it was a side effect.
I thought it was opposite. I thought it was that people were trying to improve cardiac output, and then basically they're like, yeah, but I've had an erection for 8 hours. What do I do about
Either way, Great find.
Win-win.
Yeah. Right?
Yeah, we talk about this when we talk about cardiac medications, just sort of different medications can target, they have the same mechanism of action, but they can target different areas, right? So nitro, Viagra, and Cialis all have very similar mechanisms of action where they expand vessels, but nitro specifically works on the coronary arteries very well. So nitro expands that vessel, and that makes sense. We want to open that vessel up because it's closed or it's narrowed or it's spasming. If we can open that up, we'll increase the amount of fluid or blood getting to the heart, and therefore the amount of oxygen getting to the heart. If we expand that vessel, though, we need to also understand that relatively we're dropping blood pressure, right? Mm-hmm. So there's a lot of nuance and argument into, okay, well, if someone is hypotensive or if they have the potential to be hypotensive, depending on where blockage is in the heart, if I give nitro, could I technically bottom out their pressure by opening the vessels and reducing the amount of fluid because there's not enough fluid in the system? Okay, so that is a consideration you need to make. Your protocols will dictate whether you use nitro in all STEMI cases, in all angina cases, or if there are certain, for instance, like a right-sided MI, if you'll hold off on that. My recommendation is always just call for orders. If you have a right-sided MI, that's the one that has the potential of bottoming the pressure out. Just call your ER doc, your local ER doc, and say, hey, I've got a right-sided MI. I'm suspecting a right-sided MI. Would you like me to withhold nitro? That's the safest way to do it.
Yeah. I also feel like, and this is, again, follow your protocols, both in hospital and on the road, depending on what kind of provider you are. But there's also like an argument that like nitroglycerin, if you're bradycardic, might not be a great idea either. You already have a low heart rate, and then if you did like lower their blood pressure, now you have like even more. I mean, again, follow your protocols for it, but
yeah. So oxygen, aspirin, nitro, and then we would move on to an analgesic. So in the MONA protocol, we're referring to morphine. Sometimes you may use fentanyl, you may use other pain medication. The reason why morphine was for the longest time preferred is that morphine actually has some coronary vasodilation effects as well, just like nitro does. So it helps open up the vessels as well as take care of the pain. Now, why is taking care of the pain in acute coronary syndrome, besides just being nice, why is that important in terms of reversing an infarct or preventing an infarct?
So the idea is that what are the things that are going to increase strain on the heart, right? Increasing your heart rate, increasing your blood pressure. These things are going to actually like potentially make things worse if you've got a blockage there. So what analgesics do is that they calm you down, right? So they almost like de-stress you a little bit. They take away the pain, so the pain is not a stressor anymore. Your body's more relaxed. So you don't have spikes in, heart rate. You don't have spikes in.
Oh my gosh! See what that did there is Chris's heart rate is skyrocketing now because he's scared.
Wow!
Into kind of like a
man.
Some
Thank God I don't have plaque buildup.
Right? So he's scared. His heart rate's up, right? Which is why calming a patient down, giving analgesics that will calm them and take away the pain is going to help.
I would like the fentanyl now. No, I want fentanyl now.
It's going to be okay.
No, I want fentanyl.
No, this is important for our audience to realize that calming a patient and being kind to a patient and compassionate care goes a long way in truly saving lives because it lowers that workload on the heart.
That was a great demonstration.
Thank you.
That was really scary.
Sorry you're the back above it. And I'm sorry, Jamie, who's going to have to edit the sound so it doesn't like blow out the speakers. So, okay, that is ACS, right? So that's how we're going to treat acute coronary symptoms in the meantime. We're going to run a 12-lead EKG, and we're going to see if we can identify ST elevation. If we see ST elevation, then we're going to go ahead and let them know, the hospital know, hey, they're having a STEMI as well. So this meets STEMI criteria. The difference between an nstemi and a STEMI, so non-ST elevation versus ST elevation, is on the monitor, there's ST elevation, or there's not. In the body, what's happening is a complete blockage of a vessel will result in ST elevation. So that patient needs a cath because there's complete blockage in the vessel. If I have partial blockage in the vessel, that's an nstemi. That patient can survive with blood thinners and thrombolytics, things to dissolve the clot, right? Now, some hospitals have cath labs and some don't. All hospitals have thrombolytics. Mm-hmm. So it might change your destination depending on if they have ST elevation as well, right? So if I look at the hospital, I'm the same distance between a hospital that has a cath lab and a hospital that doesn't have a cath lab. Go to the cath lab hospital. That makes sense, right? If one's farther away, I need to see if Chris is having ST elevation. He's having ST elevation. Well, I'm going to actually bypass the per protocol, bypass the hospital that just has the thrombolytics to go to the cath lab for an emergent cath.
So this is going to raise questions like, well, wait, why don't we do and we're going to talk about stroke next. If we do thrombolytics for stroke, why don't we do them for myocardial infarction? The reality is that I don't have a good answer for you, because there's a lot of like conflicting literature as to like some literature has shown that like by giving thrombolytics in a myocardial infarction, you could increase the risk of like disrupting the fibrin clot and causing more thrombus or bleeding. But now there's actually research coming out saying that like, well, maybe we should reconsider that. Like one of the contraindications historically for not giving thrombolytics in stroke was a recent heart attack, because they're worried about like.
But we do give thrombolytics in stroke, so long as
we do a stroke, but why not?
We don't always for
myocardial infarction,
gotcha.
And like why? And what I'm just basically trying to paint the picture of is that like there is research on both ends to say maybe we should be, maybe we shouldn't be, so that's why we haven't figured it out yet, I guess is my answer. And someone's gonna say like, yeah, we absolutely should do it. I mean, cool. I don't know. I've seen the research on both. If you look up the guidelines, there's still contraindications if you've had a recent MI to not give thrombolytics in stroke when we're reconsidering that in some of the literature and stuff like that. So just worth noting.
Cool. Yeah. Bottom line though is that we do the ST elevation not to change our treatment in any way. We're still going to do mono protocol in the field. We do we do the identification of the 12 lead with the ST elevation to determine what destination we should go to, because they may fit criteria for I'm completely blanking.
Cardiac catheterization.
Cardiac catheterization. All right, that's ACS. We're 25% of the way done. We've been talking for way too long. Let's do stroke real quick, because this is really easy right after that.
Stroke's pretty easy.
What's the difference between a stroke and a heart attack? Just the organ.
Mm-hmm.
Pretty much just the organ, right? We're dealing with the same thing, ischemia and or infarct in the brain. Now, ischemia in the brain will result in stroke-like symptoms, so neurological symptoms, but
they go away.
That's what, they're going to go away after a time, because we can restore blood flow to that.
Just like your chest pain does in angina.
Exactly. Angina and mini strokes or...
Yeah, you got to be careful what terminology you use, but
yeah. Angina and mini strokes are semi-synonymous in the sense that we're...
And mini strokes is also like a term that like people don't like to use, so...
But it's a transient ischemic attack is what we call it.
TIA, right?
A TIA. So a TIA is what... If your grandma says I had a mini stroke, she probably had a TIA. So a TIA just means that there was temporary loss of blood flow to an area that showed ischemia, but it didn't result in infarct.
And if your grandma says I had a mini stroke, but she can't move the left side of her face, no, she didn't. She had a full stroke.
Exactly.
So right. I mean, like honestly, like
And what's so scary is, so I had a very good friend of mine recently had a stroke.
That's right.
Young guy had a stroke, and it was because of not a defect, but basically like a congenital like shrinking of a vessel that feeds his brain.
It's crazy.
So it wasn't necessarily blockage and stuff like that. So when he went hypertensive, it gave him a stroke because of the extra pressure on that thinner vessel. But I remember just kind of like, we talk about this stuff all the time. He's a paramedic as well. But you're sitting in the hospital and it's like, did I have a TIA or did I have a stroke? And we're like, we don't know yet. We have to wait to see if it goes away.
Yeah,
like,
right. If your symptoms don't go away.
We haven't been able to get imaging yet or anything like that. And like he didn't meet the criteria for some stuff. So it was like, we got to wait. And that waiting can be pretty spooky, right? So, but yeah, TIAs versus a full stroke or a CVA, a cerebral vascular accident, is when a CVA is when we have true infarct of tissue. And that is irreversible brain damage, death of the brain. Mm-hmm. Okay? Depending on what vessel, just like in a heart attack, depending on what vessel, we might see different things on the 12-lead EKG. Depending on what vessel, we'll see different things on a CT scan. And it's going to affect symptoms. So there are some areas that will do more weakness on one side of the body. There are other areas that will do vision or speech changes. And if you want a detailed view of all of those, you can check out our videos that are coming out very soon, sponsored by Medtronic. I don't remember what they're called. They're really long names. But the stroke Medtronic ones. Check those out.
Yep. So what's interesting with stroke is that there is certain criteria for treatments of stroke, right? So there's one, you have to identify them, right? So and again, watch the stroke videos that we did, because we really get into like what tools you use to, quote unquote, diagnose one, and then what tools you use to put them on a scale to know if you should, how big they are, how severe they are, severity scales. We won't go over that here, but basically what we do is the most important thing is to identify when was the onset of symptoms, right? If you went to bed fine and you woke up not fine, well, the onset of symptoms is somewhere in between there, right? So the last known well is what we use. The last known well time would have been when you went to bed. If I'm sitting here talking to you and all of a sudden I develop symptoms, you look at your time, that's my last known well was just a minute ago before I started having symptoms. And that's important because there's two things we look at in stroke. There are hemorrhagic strokes and there are ischemic strokes. Hemorrhagic strokes is hemorrhage, bleeding in the brain. Ischemic strokes is lack of oxygen, just like a myocardial infarction.
From a blockage or clotting or narrowing of the vessel.
Yeah, something like that, right? If it's a hemorrhagic stroke, we're not giving fibrolytics, right?
Well, we need, because blood thinners, right? We're not going to give blood thinners or clot busters to someone who's actively bleeding out because if you cut yourself shaving and I give you a bunch of blood thinners, what's going to happen to that bleed?
Right.
It's going to propagate, right? So the same thing happens in the brain. So our first and foremost priority right now, as protocol stands, is to get the patient, if we identify stroke symptoms and we've ruled out stroke mimics, is to get the patient to a facility that has a CT scanner. We don't care how high up on the chain of stroke care hospitals that is, get them to a CT scanner. Any facility with a CT scanner. If we can get them there, because we need to confirm whether it's hemorrhagic or ischemic, and then we can consider things like thrombolytics, or there's actually kind of a version of a catheterization for stroke now for larger blockages in the brain called thrombectomies, where they can go in and they can pull the thrombus out, which is really cool. So becoming more and more alike heart attacks and strokes are, even in our treatment of them, they're becoming more and more alike. Right. But we're not going to do the Mona protocol with a stroke patient because we're not trying to expand vessels in the heart, so the nitro and the morphine are pointless, right? There's no pain, so analgesics aren't going to help. We'll give them oxygen, sure, but we're not going to give them aspirin because aspirin's an antiplatelet, and if they're having a hemorrhagic, that might propagate the bleed.
And this is where the question around fibrolytics in myocardial infarction comes into play. So even in strokes, we get a CT scan, we see that it's not a hemorrhagic stroke. We know then it must be ischemic. Only if they're in a certain few hours window can we give fibrinolytics, because if they're beyond that time, we worry about irreversible damage, and when tissue dies, it becomes friable and fragile and can easily bleed. So that's why, in strokes, unless it's in that time, typically we won't give fibrinolytics or clot busting drugs if they're outside of that window. With myocardial infarction, unlike the brain, when you have lack of oxygen in your brain, you know it immediately. You develop symptoms. The heart's not really like that. So that's where it's really hard. As a doctor, I can't be like, oh, is this the first time you've ever had any symptoms of heart? You just threw a clot to your, no, I probably had chest pain before. I know I have, I know I have some plaque buildup. So that's where we just don't know a lot of times in terms of that window. Stroke's easier because lack of oxygen in the brain, you see it right away symptomatically. Lack of oxygen to the heart, you develop symptoms, but it's really hard to say, are these brand new symptoms? Are they not? So that kind of goes back to the question of why we definitely do fibrinolytics and clot busting drugs in strokes within a window, and why with myocardial infarction we're still not sure if and when we should be using them.
All right, so that covers ACS and strokes. Let's jump into our tachycardias and our bradycardias. Before we get into this, let's just briefly state how standardly ACLS would define instability, because in these protocols we're going to have a kind of a different algorithm for tachycardia that's unstable and tachycardia that's stable, bradycardia that's stable and bradycardia that's unstable. So how do we define stability?
So the way we define stability when it comes to ACLS, right, whether a patient's stable or not stable, is we look at their vital signs and we look at their symptoms. I mean, it's simple as that, right? So vital signs are going to be blood pressure, SpO2, heart rate, and then we go to symptoms.
And blood sugar, I guess you could say.
Yeah, blood sugar you put in there. Symptoms, there's specific symptoms we're looking at, right? We're looking at symptoms for some of the things we already talked about. Do they have altered mental status, or do they have signs of ischemia, in heart ischemia type of thing, right? Because really stroke and ACS are the things that we're most concerned about.
Yeah, because
anything.
An unstable patient is someone who has lack of perfusion to a major organ, right? And the major organs are the brain and I almost said spinal cord. I'm very tired. The brain and the heart in this case. So if you have chest pain, you're automatically unstable.
Right.
If you have altered mental status, you're automatically unstable. It's not normal to be not fully conscious and alert, right? Symptom-wise, the symptom that we tend to look at the most is blood pressure, because it relates to systemic perfusion. So if you have a low blood pressure, you are considered in a lot of these algorithms to be an unstable patient.
We define low blood pressure as anything below 90 systolic.
Correct.
Per ACLS guidelines. Again, like there can be arguments for other people being unstable at different parameters. We're not talking about that. We're talking about ACLS guidelines right now.
And there's outliers all the time, right? If you're a ultra marathon runner, maybe you sit at a lower blood pressure all the time, and but we don't build algorithms based off of outliers. We build them out of the general population. If you have a systolic blood pressure of less than 90, you are considered unstable for these algorithms.
We do not build, I like what you said there, we do not build algorithms based on outliers.
Right.
We build them on a cohort of white 20-year-old men who, which is actually, I'm making a joke, but it's actually true. If you look at how we, back in the day, defined blood heart rate between 60 and 100, is they actually just took a bunch of white dudes who were like 20s to 30s and took their average heart rates. Probably not the best way to figure out what the average is for also,
So that's funny that you mentioned that, is in scuba diving to figure out the dive tables for how long you're supposed to like decompress for and stuff. They used like young military men. And it's like, what a terrible, like, you know how many like not the body type of a young military man are scuba diving right now, and we're based off of their like
and that's why you see so many 60, 70-year-old men who are out of shape who scuba dive having
trouble
issues.
With decompression. Yeah, it's true. But yeah, so just something to consider. Like we do have to make some generalizations when it comes to defining stability. Otherwise, it's not a definition, right? We have to set it somewhere, right? So tachycardia is considered anything above 100 beats per minute. That's another thing, right? You might be tachycardic right now because you drank some caffeine, but you are tachycardic if you're above 100 beats per minute. There's got to be a cutoff there. You're bradycardic if you're below 60 beats per minute. Mm-hmm. So 59 is bradycardic, 101 is tachycardic.
Right.
60 to 100 is what we would call normal cardiac or just a normal heart rate.
And then so the question becomes, is that tachycardia or bradycardia unstable? And that's where we look at the blood pressure. I argue that we should look at the SpO2 as well, and we look at symptoms, right?
And you can look at the situation, right? Yeah. If I just got done running and I'm sitting there with a heart rate of 160, that's not normal heart rate for someone my age or me normally, but you know that I was just running. So you're not going to panic about a heart rate of 160, right? You have to take all these things into consideration.
And it's where reassessment becomes a key piece too, right? You don't just take one measurement and then base everything off of that. You're continuing to check vital signs and things as you move forward. So in the ACLS algorithm, to keep it simple, bring it back to basics, we're talking about tachycardia and bradycardia, the algorithms, right? Tachycardia, bradycardia. We had to decide, is it stable or unstable? And the way we do that is by looking at their blood pressure.
So let's start with stable, okay? So if I am bradycardic, we'll start with slow heart rates. If I'm bradycardic and I'm stable, so I don't have symptomatic bradycardia. I'm not symptomatic right now. No chest pain. Status. I'm stable and I'm bradycardic.
Do nothing.
Well, right, do nothing. First of all, like, how'd you end up in this situation in the first place where you even know? You know what I mean? But yeah, there's no danger in being bradycardic. If you might want to investigate it. Symptomatic.
Right. You want to look into it.
Right. Well, so like I'm a long distance runner and I will average a resting heart rate in the 40s.
Yeah.
That in someone who's 80 years old and isn't a runner, that's a concerning bradycardia. And if they don't have symptoms, maybe you need to look harder to see if they have symptoms. Right.
Yeah,
so
yeah.
Everything in consideration. That's where you bring in that provider judgment, right? But if someone is stable and bradycardic, what you want to do is you might still want to bring them in for evaluation or have them follow up with their primary care physician, but there's nothing emergent right now to stabilize, right? They're already stable. We don't need to stabilize. ACLS is about stabilization, right? It's not about long-term treatment. It's about stabilization, right? So we're not really going to do anything with bradycardia that's stable. With bradycardia that's unstable, so I'm symptomatic now. Maybe I feel woozy or I'm dizzy or I have an altered mental status or I have chest pain or anything like that, right? We're going to speed up their heart, right? So there are two ways that we can speed up their heart. We can do it pharmacologically and we can do it with electricity, right? So we can use our monitors to put AED-like pads on the patient and pace the patient, where we basically electrically stimulate the heart at a rate that we choose, and we typically choose 60 beats per minute. To get the heart to beat at 60 beats per minute, it's going to shock the heart. Every time it shocks the heart beats, and they're going to be jumping up and down kind of a little bit. Their chest is going to be jumping up and down, and we're going to speed their heart rate up by introducing electricity to it, right?
Correct.
And that is what we would call transcutaneous pacing, or TCP. So transcutaneous pacing should be done on any unstable bradycardic patient. What we can also do, and we should also do, is give them a medication that can speed up their heart as well.
Right.
And the medication that we typically choose in ACLS protocol is called atropine. A approved dosage of atropine is going to work as a chronotropic to speed the heart rate up.
Right.
So we're going to give them that medication. Now, there's not a big concern about all of a sudden making someone tachycardic with these types of treatments, especially if you're doing transcutaneous pacing. Because if I'm pacing someone, their heart rate can't go faster than what I'm pacing them at. So there's no concern. Like there was a case that we reviewed on another podcast that we talked about. Like there's not really any concern with transcutaneous pacing. They're not all of a sudden going to be paced at 120 or going tachycardic. While when you're using pharmacological means to speed someone's heart rate up, we can't cap what that heart rate is.
Right.
You know, so that's where the Edison before medicine is what we say a lot of times in terms of priority of treatment for unstable patients. Using electrical treatments tend to be a more effective and safer way to treat the patient.
Now, the problem you may run into with bradycardia and trying to use transcutaneous pacing is that if the patient's very awake and alert, it can be uncomfortable, right? You're literally shocking them through their skin to get their heart rate going. So maybe you need to give them some sedation or something to relax them. Well, you got to be careful there too, right? Because you don't want to like have that relax them so much that their heart rate goes down because they're already bradycardic. Right. So yes, you can try a dose of atropine or two. It's pretty quick most of the time to put an IV in, give a dose of atropine, see if it works while you're hooking things up. But if you have a patient who continues to be bradycardic, despite your pharmacological treatments, you have to go to transcutaneous pacing you have to do something to bring that heart rate up.
Well, and that's a big argument in EMS right now is that I think EMS providers get a little bit confused about, okay, they're unstable bradycardic. I'll start them with atropine and then I'll move on to transcutaneous if I get really worried. And it's like, no, they're unstable. If they're unstable, hook up the pacer. Right. You're not going to harm somebody with the pacer. You can make them uncomfortable, but you're not going to harm them. Right. And if you get that capture first, and then you go ahead and follow up with some sedation or some pain meds or something like that, there's no danger of that heart rate dropping because you have good capture, right? So nothing wrong with that. You've made a lot of arguments in the past for if you plan on intravenously, if you plan on inserting a pacer to someone in the hospital, if you're going to put a pacemaker in.
So in the emergency department, if I come in, if someone comes in and they are bradycardic and they are unstable, there have historically been arguments to put in a transvenous pacer, and that's essentially where I go into the internal jugular vein, run a catheter down into the atria, try to capture electric activity with that node, and then pace the heart, literally like inside, right? But what I've seen done so many times as I've come up in medical school and residency and as an attending is that residents or attending physicians, emergency physicians will work on floating a transvenous pacer and not have started transcutaneous pacing. And my argument is that if you think the patient is in such dire straits that they need transvenous pacing, that you need to go drape them, sterile technique, put a big catheter into their internal jugular vein, go down, then you should be transcutaneously pacing them, right?
Meantime,
and then the question is, if you can transcutaneously pace them and get capture, they probably should just go to the cath lab to get a permanent pace, not you know what I mean? So there are arguments back and forth on that, but I'm just saying think about what you're doing and why you're doing it. If I truly think a patient needs a transvenous pacer in the ER, the way I do it now, if I truly feel that's the case, then I have to transcutaneously pace them first.
To me, it's very similar to saying this patient needs to be intubated, but I'm not going to bag them until it's time to intubate them.
Yeah,
right?
exactly.
It doesn't make any sense. You have to have that kind of transitional treatment
100%
if it's important. So that's bradycardia. Essentially, so one thing, no, that's it. I'm mixing it up. Yeah. So
there's
other chronotropics that you can give as a second consideration. So you can, if those treatments aren't working, you can move on to more of like a catecholamine drip to speed up the heart. You could do like an epi or a dopamine and use its chronotropic effects to speed up. So you could do like basically a catecholamine drip where we're doing a drip rate of epinephrine to speed the heart up and do it that way. Those are a little bit more long terms if we're talking EMS. But typically transcutaneous pacing, if you can get capture, that's going to do it for you and you're going to be good to go. So
you can consider push dose too. I mean, they're that's not an ACLS guideline, so
that's what we're shifting to a lot right now.
Yeah. So it's not currently in ACLS guidelines, but you can do push dose epinephrine to just keep the heart rate up while you're trying to get atropine working, while you're trying to get transcutaneous pacing working, while you're trying to transport so they can go to cath lab for a pacer, things like that.
And then tachycardia. So if we are stable but tachycardic, there's a couple things that we can do to try to non-invasively slow the heart rate down. And the first thing that we would consider would be...
We didn't mention, though. We need to go back to bradycardia, vagal maneuvers.
No, that's tachycardia. I'm about to say it.
Perfect.
I did the same thing, though, because the way I have it listed on here is...
Okay, perfect.
So, yes, so a non-invasive way that we can slow the heart rate down is vagal maneuvers. Vagal maneuvers are essentially activating the vagus nerve, so activating the parasympathetic nervous system in your body through natural means. So one way that your body activates its parasympathetic nervous system is when you're pooping. So if you bear down, you flex the muscles that you would when you poop, that will actually lower your heart rate and kind of slow down your metabolism. It'll work on the parasympathetic. So we can ask people to do that. Hey, I need you to bear down. And you might need to explain what bearing down is, because some people don't know. It's also important to tell them not to actually poop. Sure. I've had that happen where I'm like, you need to kind of like flex like you're going to poop, and then the patients just poop themselves.
Right. But you know what? A small price to pay in order to get your heart rate down.
This was a large price. So anyway,
another thing you can do. So I've seen this where you have them like blow into like a straw, but like that's capped. Yes. Right, so there's like blowing against something that like they can, like that was the same thing, right? So it's a version of bearing down, but it's something maybe easier for them to understand. Like blowing into that closed.
They've actually been doing this technique in ERs lately, where they have someone blow through a straw and then they swoop their legs at the same time, and they like give them that like
fall.
They make them have the feeling of falling. So they like do this whole weird thing, and then that's supposed to be like really effective. But it's always been funny to me because it's like, how did they come about discovery that, like, how many weird things did they do first, But there's a couple other ways to activate. Cold compresses on the back of the neck and things like that work great.
And if you think about it, like when you jump into a cold pool and you're like, that kind of like, that's right? That's that vagus nerve being like stimulated. So like with children or babies too, like you can't tell them how to bear down. So you take like a cold bag of saline or like ice and like put it on their face and just kind of get them to like
that shock,
get that kind of that shock feeling. Yeah.
Yep. Something that you may have heard of before that we no longer do is a carotid massage. So we do not do carotid massages anymore, because what would happen is when we massage that area, though it can activate the vagus nerve, it also can like grind up plaques that we have in there, and like potentially those plaques could then break off and go up into the brain and give us strokes and things like that. So we stay away from carotid massage.
That'd be the worst.
That would be
the worst.
Yes.
You're like symptomatically bradycardic and then stroke out.
Don't do carotid massage. We don't do it anymore. Cool. So that's your non-invasive means. Then you would move on to, if they're still, if they're symptomatic but they're stable, it kind of all depends on what you're dealing with. But if you want to move on to further treatments, you can consider pharmacological intervention.
And I'll say for unstable tachycardia, like the blood pressure's off, they're symptomatic. Like, yes, you can still try vagal maneuvers while you're getting the other things ready, right? You shouldn't forego pharmacological treatments in unstable tachycardia to do vagal maneuvers. But as you can see, like, it's pretty simple to do vagal maneuvers. You can do that quickly while someone's establishing IV access. You know what I mean? So
the next thing that we would move on to with stable or unstable is we can consider pharmacological measures, which would be adenosine. Now, remember, with unstable treatment, we do have that kind of rhyme, Edison before medicine, where we're always going to consider the more effective treatment of electrical intervention. And the electrical intervention is cardioversion, which we'll talk about in a second. But I just want to talk about the pharmacological that can happen, as a non-responsive to vagal maneuvers. So we want to move on to adenosine, or we're already cardioverting and we also want to add pharmacological interventions to it. I guess is what I'm getting at. Does that make sense?
Yeah, it makes sense.
Because people get confused. They think like, oh, pharmacological is for stable. Well, if you're stable tachycardic, you don't always have to you
don't always have to bring the heart rate down.
And then you can just consider, like, you can just monitor them and keep them comfortable, right, and have an expert review and take them to the hospital.
Right. Like if I have somebody who comes in who's tachycardic at 200 beats per minute and they're stable and it's like AFib, I'm not giving them adenosine. You know what I mean? Like I'm going to other medications that are approved for that condition. You know what I mean? So like,
I would argue that if you're 200 beats per minute,
you're probably unstable.
Probably in VTAC, there's no way you're stable.
Right. So is it worth talking about identifying the complex first?
Yeah, so you do. I don't know if it is, because the algorithm doesn't really change.
Sure.
Tachycardia is tachycardia, and we're really concentrating more on stability. There are some medications that are better for wide complex tachycardias than adenosine, which is what we're talking about now, would be. And if you have like an irregular rhythm, you typically want to stay away from adenosine. Adenosine works on the junction of the heart. So essentially it's going to slow down the impulse right at the AV node. So if you're generating a heart rate below the AV node, like a ventricular rhythm, adenosine won't work on it anyway.
Right. So there is, if you look at the ACLS algorithm, there's technically like two tachycardic. There's narrow complex tachycardia and there's wide complex tachycardia. And I think as we're trying to bring it back to basics, we're talking about addressing the unstable patient in general with pharmacology and electrical. But if you have a narrow complex tachycardia, we sometimes define that as like an SVT. That's where we would try adenosine, because adenosine works at the junction, and we know that if it's narrow, it's coming from above the junction. But if we have a wide complex tachycardia, adenosine's not going to do anything. So we can skip adenosine and go right to the electrical.
And that's where like AFib with RVR and things like that, some of these irregular rhythms, that's why it's so important. The second thing we do is we look for regularity, because we need to figure out, is our heart rate just fast, or is our heart rate fast and irregular? Because if it's fast and irregular, then we want to consider medications like antidysrhythmics. So that would be like things like amiodarone, lidocaine, things like that, which we talked about a little bit in the cardiac arrest treatment stuff. So amiodarone is kind of your go-to for, right now at least, for irregular heart rates when traditional treatments aren't fixing it. But just talking about adenosine, yes, this is mostly for supraventricular tachycardias, so tachycardias that are generated above the AV node or at the AV node. And what it does is it slows down the heart. So it captures that impulse and holds that impulse there, doesn't let it go into the ventricles for a little bit, and slows down that heart rate.
It works on the AV node. Adenosine works directly on the AV node. So that's why it's only effective in supraventricular tachycardias.
Yes. In terms of giving adenosine, it needs to be given very quickly. So we typically will follow this. We'll do this IV push, rapid IV push, and we'll follow it with a flush. And we'll usually pinch off the line as we push it, so that there's nothing in between. It's just that full bolus of medication. It has a half-life of like 6 seconds or something like that.
But you have to let your patient know they're going to feel like garbage for like a couple seconds.
So if I force your heart to all of a sudden stop for a second and really slow down, you'll actually see these patients sometimes flatline for a period of time on the monitor, just a couple seconds, but they're going to feel that too, and their body's going to start going, oh, something's wrong.
Like there's like an impending doom type of thing. Like, why is you stopped your heart for a second?
So let them know they're going to feel kind of lousy, and make sure you push it rapidly. Moving on to electrical, cardioversion is what we'll do for tachycardias. If they're unstable and they're tachycardic, I recommend cardioversion right off the bat. You can do this at the same time as adenosine. You can do it before adenosine if you want.
If it's SVT and it's unstable, like their blood pressure's low, they're symptomatic, their altimeter status, cardiovert them, right? Yes, you can try adenosine as you're getting ready for cardioversion if you'd like. Wide complex tachycardias, ignore adenosine. If they're unstable, you go right to cardioversion.
Yeah. So cardioversion is basically it is not a defibrillation. It's a synchronized shock to the heart. And what we have to do is we have to program the monitor to basically mark the R waves so that we're shocking at a very specific time. So you'll see little arrows pop above the R wave when you sync a wave, and then you go ahead and give synchronized cardioversion where you shock the heart. If we don't synchronize, it's essentially shooting without aiming. And if we do that, there's a potential that we can shock them during the refractory period of their heart's electrical activity, which is the time that the heart is resetting to be able to depolarize again. And if we shock someone during that time, we can potentially put them into very dangerous rhythms. So it is very important that you just do one thing.
As in like asystole.
Yeah. Well, or right. VFib, right? So you can make them pulseless. You can kill them by shocking them on the wrong spot. All you got to do is remember to hit the sync button. Just hit that sync button and you're good to go. And then we usually shock in stackable dosages. So we start at a manufacturer recommended dose, and then sometimes that goes higher and higher. You always shocked at kind of a standard dose. You usually stayed pretty high when you were in the ER.
So and I did this on your protocol. Yeah, I did this for a reason. So I think, and correct me if I'm wrong, but if the ACLS algorithm itself calls for a range of, what is it? It's
it depends on the monitor, actually, but like 100, then 200, then like if it's a standard shocking stackable dose would be like 100, 200, and then 400, 300, and then max. You can't shock at 400. A lot of them max out at like 360.
Okay. But I think if you look at the ACLS guidelines, it says that you can start at 100, and if that doesn't work, go to 200.
Yeah.
I just always did 200.
Yeah.
I usually got to sedate someone for this anyway, right? I mean, you're not going to, you can't like cardiovert somebody who's awake. I mean, you can, and if you have to, you need to.
Yeah.
I always try to sedate them, give them something, right? a lot of times even you give them something, they wake up, they're like, holy, you know what I mean? Like you're shocking them hard. But like, if there's a chance I'm going to have to do it a second time at a higher dose, it was just easier just to do it at 200 to begin with.
And you have that prerogative because you can practice medicine. Don't EMS providers and nurses on our RT teams that are following protocols
start at 100.
You got to do the manufacturer recommendations, and it's probably going to be stackable doses unless a doctor orders.
There's actually arguments now and research that shows that you can like double stack them. So like literally like hook up 2 different monitors and shock them at the same time with both.
What?
Yeah, I don't know. Weird stuff.
Interesting. But that is how you would cardiovert someone. So Chris mentioned the sedation thing. You may not have sedation protocols. Pain meds are fine. It's a one-time shock though, so a pain med's not going to be really helpful.
If a patient is unstable, it is more important to try to make them stable than it is to make them comfortable, unfortunately. You know what I mean? Like for them. But like honestly,
anytime that I have cardioverted, there has been no sedation. Because if I'm cardioverting, I'm in the back of an ambulance and I feel like the patient's severely
well, and if they're truly unstable, like they're probably altered anyway a little bit. Like, I mean, like hopefully they don't remember. Or if they do, they're alive to remember. So
all right. So that covers brief review of EKG interpretation, stability identification, ACS, stroke, tachycardia, and bradycardia, and that brings us to the end of our review of ACLS.
So I will say the one thing too for these tachycardia and bradycardia algorithms: if at any time the patient becomes pulseless, you change over to the cardiac arrest algorithms.
Yeah, so that's worth mentioning, right? These aren't like, hey, he's having chest pain, so he's in this box of ACS protocol, right? Like you can be tachycardic, and because you're unstable tachycardic, it's causing chest pain. So it is up to you as the provider to kind of figure out what algorithm you're going to be at what time, right? And there can be a lot of, okay, is he having a heart attack and that's thrown off his electrical rhythm now, so he's bradycardic because of that? What is the underlying cause? And that's only going to happen through good assessment, history taking, understanding your situation, and knowing your stuff. It's not going to happen from a deep study of the algorithms.
Right. You also can operate in 2 algorithms at the same time. Correct. And I'll just make a note of this. I won't reference anything. But if you have a patient who is bradycardic and having severe chest pain, and you think that they may be having myocardial infarction, you can treat their bradycardia and should treat their bradycardia because they are unstable. They're having chest pain. That is unstable bradycardia, as well as give them aspirin and nitro. And or you know what I mean? You can do that and should.
I would also say something that I would see all the time when teaching ACLS is it's a very common ACLS test, like one of the scenarios where you have a patient that is in rosk. So they were in cardiac arrest, and then we return to spontaneous circulation, and their heart rate's real slow. And the first thing that people do is like, okay, their heart rate's slow, I got to get that up. I'll go ahead and give atropine. Mm-hmm. It's like, well, wait, I would consider this patient to be pretty unstable since they were dead 30 seconds ago, right?
Right.
We can, and there's already pads on them because we've been shocking them. Right. Pace them, just pace them in rosk, right?
For sure.
Get their heart rate up by pacing. It makes way more sense.
Yeah, absolutely.
Also, like that med's not going to circulate very well if
you just got rosk.
They were dead.
Yeah.
Something to think about.
Cool.
That is going to end our episodes on ACLS. If you want a CE credit for this, go check out guardiancme.com, and we'll see you next time. Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.